Good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. First of all, let me wish you all a very, very happy new year and welcome to this first episode of the ACNS webinars of the year 2024. The speaker for the first session of today is our honorable guest from Singapore, Prof. Vincent Eng. Prof. Vincent is the head of Department of Neurosurgery at the National Neuroscience Institute, Singapore, and is also the co-director of the Endovascular Center and the Director of the Joint Neurovascular Services at the National Neuroscience Institute. He is the current Vice President of the Clinical Neurosciences Society and immediate past Chairman of the Chapter of Neurosurgeons, Academy of Medicine, Singapore. He is also a member of the Congress of American Neurological Surgeons and American Association of Neurological Surgeons. He is an expert in endoscopic skull-base surgery as well as cerebrovascular surgery. He was the past president of the IFNE Congress, which was just concluded in Singapore, and we are extremely grateful to him for accepting our invitation to be a speaker at our webinars. And today we'll be talking about decision making in unruptured aneurysms. The speaker for the second session of today's webinar is our honorable guest from India, Prof. Jayanand Sudhir. Dr. Jayanand is an additional professor in the Department of Neurosurgery at the Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, Kerala, India. His clinical interests are focused on cerebrovascular neurosurgery, and his center is one of the main centers in India focusing on the comprehensive management of Moyamoya disease. He has accomplished the feat of more than 150 bypasses for complex cerebrovascular diseases. We are extremely honored to have him today at our webinars, and today we'll be talking about, does arsenic have a role in the pathogenesis of Moyamoya angiopathy? The chair for the first session of today's webinar is our honorable faculty from Chile, Prof. Jorge Mura. Prof. Mura is an adjunct professor in the Department of Neurosurgery at the University of Los Andes, Santiago, Chile. Prof. Mura is a master of Chilean neurosurgery and was the past president of the Chilean Neurosurgical Society. His clinical interests are focused mainly upon cerebrovascular surgery, and he is known for his favored minimally invasive transcavernous approaches known as MIPLATA. He is also a propagator of the surgery for ischemic stroke, and we are extremely grateful to him for accepting our invitation to chair the session of Prof. Vincent. The chair for the second session of today's webinar is our honorable guest from Japan, Prof. Yohei Minaharu. Prof. Minaharu is an associate professor in the Department of Artificial Intelligence in the Healthcare Medicine, Kyoto University, Kyoto, Japan. His clinical interests are focused on Moyamoya disease, especially its genetics and mutations. He is also known for his discovery of specific gut microbiota associated with Moyamoya disease. We are extremely honored to have him today, and grateful to him for accepting our invitation to chair the session of Prof. Jayanand Sudhir. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Prof. Shubin for broadcasting this webinar on the WeChat channel. Dr. Lubun Singh from Malaysia and Dr. Joey Sam from Malaysia, both are my co-hosts for today. And with that introduction, I would like to hand over this podium to our first chair, Prof. Jorge Mura.
Thank you very much, Raja, for the invitation, and for me it's a pleasure always to be in the ACNS education, and it's a big opportunity to share. From very far, we are talking before that we are 12 hours apart and thousands of miles, but we share the same passion for neurosurgery. And for me, it's a great honor to share this session about the decision making in unruptured aneurysms. For me, it's an honor to introduce Professor Vincent. Raja, you already show what his extensive experience in this subject. And I have my idea in the decision making in unruptured aneurysms, but I want to leave Professor Vincent and before made his lecture, and after that we can discuss about what we do actually in our clinical practice. Sometimes we have all the evidence, but when you are in front of the cases, you need to make a decision because the patient want an answer, don't want a paper, want an answer about the problem. And it's very important to share different point of view in order to have the better answer for these patients. And for me, it's an honor to introduce you, Professor Vincent, and please show us our lecture.
Thank you very much, Professor Mura, for your kind introduction and sharing for the session. And also thank you, ACNS, Professor Raja, and also Dr. Liu and Isam for the session itself. Today, my topic is on decision-making in unruptured cerebral aneurysm. aneurysm itself. When we first start off, I think it is important to consider what actually leads to and what it really means when we say that about aneurysm formation. It is characterized by the disruption of the internal elastic lamina with the thinning of the media itself, the reduce of the smooth muscle cells, and then you have the occasionally disruption of the endothelial when you have rupture, and also the presence of the inflammatory cells. On top of that, you would have the remodeling process, but which is maladaptive, and that actually also leads to a factor for a formation of an aneurysm. And when we combine that and consider the hemodynamic factors, such as at the arterial bifurcation, where there is high washer stress or high washer stress gradients itself, these would actually lead to what we know for the formation of an aneurysm. If you now look at this pictorial between a normal cerebral artery wall, you will then see that in the lumen, you have the endothelial cell, the basement membrane, the internal elastic lamina, and then the tuner media, where you have the smooth muscle cells. In looking straight into the aneurysm wall itself, then you find that the smooth muscles is much less. You would have still the collagen fibrin, which fibrils, which we'll be talking about a little bit about the collagen remodeling. But it is really the breakthrough of the lack of the IEL and also the lack of the smooth muscle cells that truly define what it means by the true sacral aneurysm. If we move down into a slightly more micro level, I know this is a very complicated slide, but it is important because this lays the foundation of what we understand about unruptured aneurysm. Firstly, you would have the normal hemodynamic workflow, blood flow, all right? And then that gives a factor to the endothelial cell here, and through the various mechanisms affecting from the nucleus of the endothelial cells, leading to various inflammation cycles by encapsulation of the macrophages into the cells itself. And you also have the interplay of the smooth muscle cells here through the secretions of all this kind of factors, the MCP, MMP2, and capsaicin, that leads to the extracellular matrix degradation, and together with the ACNS and all the inflammatory pathway, leading to the formation and the progression of forming intracranial aneurysm. And by understanding this, it will then help us to subsequently risk stratify the aneurysm. We start off by knowing how common is an aneurysm. And unfortunately, it is fairly common. And because it is fairly common, you have a range of about 2% to sometimes 3.5%, depending on the study and the study group itself. But it's important to know that it's not necessary to treat all the cerebral aneurysms if they are unruptured. And therefore, you do need to then decide on when you have and patients present with you to you for an unruptured aneurysm, there is a decision that you need to make. Do we need to treat this aneurysm? If you allow me to take a bit of time to go back to the best study, the natural history, looking at it starts with the ICU study. There was two study in 2003, where then they look at the size, the location, and then we were looking at a 5-year accumulated risk of fairly low percentage. And so this was one of the definitive study. On top of the looking at the location or the size, the patient epidemiological factors led by the paper by Professor Wrinkle, then starts to tell us a little bit about the various factors that we need to measure or to at least to understand. For example, the gender itself for females having a higher relative risk. We also know that with increasing age, there's also a relative increase in the rate in the risk of aneurysm rupture. Subsequently, in 2007, there were other risk factors that was then considered, where you have hypertension from the patient's risk factors increasing the risk of rupture, whether there's a history of smoking at a risk of 1.7%, and subsequently for Japanese or Finnish population, really based on the established literature, that you have a higher risk of rupture. So that's still looking at the patient risk factors. Recently, the consumption of various medications by our patients need to be also considered because, and it is intuitive to understand that if you have hypertension and we are able to control it well with calcium channel blockers, you may then have a lower incidence of aneurysm rupture and growth, and similarly with beta blockers. When you look at what we discussed just now about hypertension, age, smoking history, and a whole host of other risk factors from the patient point of view, these are the various speculations on the factors that lead to the disease initiation of an aneurysm and the disease progression. For example, in hypertension, you can have leading to excessive hemodynamic stress, high abnormal forces, high shearing forces. With the age itself, you do have increased stiffening of the vessels, weaker tone regulations. So there's a whole host of factors. If you have a history of smoking, you have higher blood viscosity, nitric oxide inhibition, the smooth muscle cells phenotypic changes, and the inflammatory pathway that we talked about just now, that can also then lead to the formation of aneurysms and the progression. That is really still looking at the patient's risk factors. If you then go back into looking in the aneurysm risk factors, which was hinted to us by the ICU studies, then the location, the site of the aneurysm, the size of the aneurysm, and the type of the aneurysms will correspondingly give us a relatively increased risk based on where we are. If we then also have to look at not only the size and the location, this is very historical when you look at a two-dimension shape where you then decide to describe the aneurysm in various indexes of shape index, be it the undulation of the aneurysm, the aspect ratio, the ellipticity, the NSI. So these are all the other factors when we look at aneurysm. How do you put that together in order to say that, well, if you have a highly undulated aneurysm, this is the aspect ratio or the bottleneck factors that may increase the risk of the rupture. We learn to describe our aneurysms better by looking at various parameters, be it in the perpendicular dome, the maximum height, the flow directions, and the morphological structures. We put that together then into the patient's artery, looking at the patient parent artery geometry as well. That is also something that we have to look at in terms of whether it's at the apex of the bifurcations, what is the sidewall aneurysms in the curved vessels itself. In this paper by Kempis, it also mentions that sometimes if you look at what this study is talking about in the 3D morphological changes of an aneurysm before and around the rupture, what it says is that before the rupture, the size parameters actually increased, and around the ruptures, the size parameters and other morphological increases. And the conclusion of this paper was that increase in the aneurysm volume and the surface area may be then the risk factors for aneurysm rupture. But post-rupture morphology of the aneurysm then should not be as a surrogate for pre-rupture morphology. And so that's a very important that, fortunately, most of the time when we are looking at an unruptured aneurysm, we are no longer looking at a post-rupture morphology, but we are still emphasizing. It's important, therefore, to understand this of the surface area and the aneurysm volume. What do we do currently or most commonly with all the risk factors that we have considered just now? Then development of the FACES score, which is very well known. When you look at the population, hypertension, age, size, early aneurysm history of SAH, and S of the site of aneurysm, and therefore forming the synonym FACES. And by calculating the score, it then gives you the estimated 5-year risk. There's also another score that one can look at, which is the ELAPSE score, which also considers similar risk factors as we described in just now about the aneurysm row risk, whether there's earlier SAH itself, the location, the age, the population, and the size of the aneurysm. Together with that, you also have with the Japanese cohort and the UCA study, also telling us some of the various risk factors that we have, and then the size. What then one puts in together is this UIATS score, which is fairly instructive and useful in our clinical practice, at least personally, where you consider the patient's age, the various risk factors, incidents, the clinical symptoms related to the unruptured intracranial aneurysms, and what is the expected life expectancy of the patient, and the comorbidities of the patient from all this at the patient point of view. We then look at the treatment risk, what is the age-related risk, the aneurysm size-related risk, the complexity of the aneurysm, and also the interventional risk involved. And that, by submitting the score, will tell us whether you should or should not treat the aneurysm. And so that's fairly instructive based on these various scores. And you can, with the website of what you reckon here from the Geneva in the Switzerland study, you are able to then calculate the various components all together at once. But that's really what we are looking at, really much more at the clinical side. It is what is new or fairly standard now with the computational fluid dynamics is whether when we look at the aneurysm, besides considering all the factors that we have, would CFD also give us additional tools and power to predict the risk? And then with this new technique of just looking at the hemodynamics itself, you can look at the wall shear stress, the various factors that has been described here, such as the inflow jet, the impingement zone aneurysm, where the definitions of these various parameters may help to actually characterize the shape, the aneurysm in front of us, for us to then determine the various factors. Unfortunately, these hemodynamic parameters, as I can share in this paper, there's many very highly well-defined mathematical models to get these parameters. And it's then difficult to understand which of these factors, for example, the WSSG, OSI, is the most important factor that you should be looking at, or a combination of these factors. And you also need a certain degree of technical experts to be able to actually understand and to generate these various parameters for the unruptured aneurysm. And so, besides looking at the hemodynamic factors, what then the technology has moved on is also to look at the structure and therefore the fluid structure interactions of the aneurysm itself to predict the aneurysm risk at a research point of view. We then also see, for example, in this case, looking, for example, at aneurysm in the parent vessel, and then looking at the factors such as natural frequency of the aneurysm, on how well and how is the wall fluctuating to predict the risk of the aneurysm rupture. Just hot off the press, it is also something on investigations, really also looking at how the aneurysm sounds like through this high fidelity FSI interaction modeling, giving us another future factors that we can consider when we are looking at the specific aneurysms. And these are fairly highly technical, and it's therefore need to actually bring it down and simplify for future clinical practice. So if we look at the aneurysms, how do we then look at? You can acquire the 3D imaging status, segment it out, do processing, do geometric analysis, and then you have also the predicted hemodynamic velocity, the mechanical stress. So all these geometric factors of the aneurysm, the velocity informatics of the aneurysm, the shear stress aneurysms that will lead you to further risk assessment of the aneurysms that we talk about. Now, Meng presented this theory, which was very interesting in 2014, we're saying that when the starting point of all aneurysm is really for the high washer stress, where the endothelial cell then sensing that with the mural cells producing the metallase degenerating factors itself, causing the SMC changes and loss of the internal elastic membrane, as we mentioned earlier, starting to form the bulge of the aneurysm. And then it led to two different kind of pathway. Right? One is really the inflammatory cell pathway, where you have then the endothelial cells being pro-inflammatory, having inflammatory infiltrates producing MMP with the matrix degeneration and the inflammatory pathway. The other group is when they have the growth with this high washer stress itself, but causing the mural cells to be the one producing the MMP with the matrix degeneration. And so there are two pathways that can form, and that either lead to the rupture or stabilization of the aneurysm. So if you look at the hemodynamic, biological and mechanical pathway, the high washer stress, positive WSSG, leading to the mural cell mediated destruction remodeling, then you would lead to this kind of small aneurysm, very thin wall, translucent, acellular. The other group, which is low washer stress, high oscillatory index, with the disturbed flow, leading to the inflammatory self-mediated destruction remodeling, leading to those large, thick wall atherosclerotic thrombotic aneurysms. And really, this is what we see in the clinical practice, where you have either the formation of the aneurysm, which is fairly thin wall, like this, or the very complex, thick wall, partially calcified, partially thrombosed giant aneurysms. So, and that truly is the very interesting theory that's really given by this paper itself. And moving forward beyond looking at inflammatory, and we see that in the pathway itself, we now have different models of looking using modern techniques such as the Mendelian randomization, which helps to remove the confounding factors to look at whether inflammatory markers, in this case for just the FGS-9 or the FGS-16, with the risks of that predicting the unruptured aneurysm. So while we were talking just now a little bit about the inflammatory pathway, the hemodynamic, the mural cell pathway itself, the other important process when we went back to the first two slides was about the remodeling of the collagen. And there you have actually the various theories on what is the stress induced, which is basically what is the actual force on the per unit area leading to the amount of collagen and remodeling, and also the stretching and the straining of it, also determining the amount of the collagen and recruitment. And then the various models where you have either all in the same direction, isotropic or anisotropic. So this whole concept of collagen remodeling then gives us another theory on how you can discuss about the aneurysms at a research basis. So you start with the hemodynamic analysis of the aneurysms, velocity, the washer stress, the pressure, looking at the hemodynamic forces, then do structural analysis, and with this, predict the tissue deformations and the stresses, looking at then therefore the degradation and the remodeling of the collagen with the stretch-mediated collagen remodeling, and also the destruction of the IEL, then therefore the elastin degradation. And each of this process then will then affect further up structural and the hemodynamic factors. And that's really what you call the fluid structure model. On top of that, because of the remodeling, then you look at the various factors below the formation of the collagen with these various other factors that slowly gets be able to associate with the remodeling, and that also becomes a way we can then look at the rupture risk of the aneurysm. And therefore, we have this aneurysm paradox where you have some of the aneurysms that form fairly quickly and they rupture, and sometimes they stabilize and for the long time, the small aneurysms never grow, and we follow up, they actually have very, very low rupture risk. So is on the other hand, these aneurysms then subsequently can grow and then rupture with increased size. So it really depends on whether the aneurysm wall stabilizes. If not, then they actually form fairly early, quickly, and they rupture. In clinical points of time, we also want to view and see, besides looking at the 3D morphology using the CT angio DSA, the degree of inflammation. And the latest what we do see is with the gadolinium enhancement of the wall, with the black wall imaging, to see whether the wall of the aneurysm enhances with gadolinium. And this was the various protocols that you can use to look at whether it is the no wall aneurysm wall thick enhancement, full or thick and thin, in order to characterize the aneurysm. But this paper that just came out from the European Society of Radiology does instruct us that gadolinium enhanced intracranial wall imaging and looking at the risk of the aneurysm. What it says is that the aneurysm wall enhancers does predict growth and rupture if it enhances, but it is unfortunately not independent of size. Therefore, the fruit hazard ratio with enhancement is actually at 3.1, and adjusted is at 1.4. And you can see the risk of growth and rupture in the aneurysm with and without enhancement as being much more significant on the upper line with wall enhancement. Unfortunately, it is still, in this paper itself, concluded not really recommended for short-term prediction of the aneurysm growth and rupture. Now, looking into the future, aspirin, if you're talking about inflammation, therefore becomes something that is interesting to investigate, because we know that aspirin is anti-inflammatory, and does that help to decrease the incidence of cerebral aneurysm? And these are the papers who then say that in the multivariate risk analysis, patients we use aspirin 3 times weekly to weekly actually has a significantly lower odds of hemorrhage. And in this paper, it mentions that frequent use of aspirin may be protective from that point. But some of us will be a bit worried about using aspirin to prevent the risk of rupture, really because of the antiplatelet effect and the worsening outcome if the patient is on antiplatelet treatment upon the rupture of the aneurysm. We will wait for this trial, the PROTECT-U study, which is the prospective randomized trial to evaluate the patients with BP monitoring and ASA or no ASA, to see what is the result of this trial. And currently, I know it varies with different institutions whether aspirin is used for unruptured aneurysm. And it's interesting also to consider then that beyond aspirin, clopidogrel, there's some isolated literature that also reports with reduced likelihood of aneurysm SAH in this particular retrospective study. Because I mentioned this technique just now about the Mendelian randomization. I'm not the geneticist, but it's interesting then to see how this paper mentioned that with coffee and tea consumption, that the odds of 1 cup a day increases genetically predicted coffee consumption at 1.2 for the risk of the aneurysm rupture. The other very interesting risk factors that have been discussed about the brain morphology and the phenotypic profile of the patients with that, and it seems that there's a difference in how the phenotypic of or the morphology of the brain itself may be associated with an ruptured aneurysm. What then is the technique that we can put everything together? Because we have so many factors to consider, and at clinical we already have the ELAPSE, the FACES score, and all that. And what we are hoping then is to plug everything inside, give all the risk factors of the patients, and using the latest technology and statistical analysis to predict the risk. So you will then see this machine learning where you do rupture risk assessments of this by decision tree modeling and statistical machine learning techniques. It is important with this day of AI and machine learning to understand what it means by the data that you put in, whether it's a supervised learning or unsupervised, and the various methods of machine learning that is over here that is then used to actually do prediction, and whether the algorithm is what you choose, and whether the model, the machine model that you choose in this various network will be the one that able to predict properly. So just now I mentioned a little bit about the FSG model. So for example, you will put in the clinical parameters such as genetics, the clinical risk factors of the patient. You can consider putting in the hemodynamic parameters, such as the washer stress, and then the washer stress gradient, the OSI index, and the various modeling constraints, putting in predicting the elastin and collagen remodeling, and use that to predict aneurysm growth. And with this FSG model itself, you can then do in silico using the computer to simulate a large amount of data and use that for model training, and subsequently then verify that with the clinical data. This is another way of what we are saying, that you put in the clinical risk factors for the genetics, hypertension, smoking, gender, age, and then the aneurysm morphology, put it into a predicting tool using AI, and hopefully they miraculously come up with the growth rate and rupture risk. That has been done by the leading centers in the world. And for example, in this case, you would then see one center putting in the clinical data, the radiological data, and looking at also the various serum samples, the metabolomics, and the cytokine samples of the patient itself, forming a small discovery cohort first, and then using these data, right, of the 758 patients for a derivation cohort, and then using a subsequent cohort to validate the prediction model. So you would see, for example, they looking at the various markers, forming, establishing the model, and then validation of the model from that to predict the risk of the aneurysm rupture. And then you have to then assess the model by how is the performance of the model as well. The other, I guess that's really at this moment now what we are talking about in the future, where if you are able to put in all the data that you have in using AI to then look at the risk of the rupture of the unruptured aneurysm. The next more slightly new paradigm shift then is this paper that talks about, interestingly, while we were talking about the hemodynamics, the patient risk factors and all that, is this dysbiosis of the gut microbiome then associated with the rupture of the aneurysm itself, where it seems to be that the gut microbiome as an environmental factor may also make a difference whether stable aneurysms leads to an aneurysm rupture. And then this paper itself then defined that the gut microbiome profile varies difference from patients who have stable unruptured intracranial aneurysms, and they found that it's associated with these two groups of bacteria, such as the genus Campylobacter or the Campylobacter urolithecus. There seems to be multiple papers coming along with looking at the gut microbiome data itself. But in this particular paper, then it was really looking at a slightly different bacteria. So the literature review doesn't seem to converge, and I guess it really depends on the cohort of the patients that they have, and the gut microbiome could be different in different populations. With that quick summary, I've just taken everybody through what we read, at least I generally look at, and what is the latest in terms of the CFD parameters, and where we can use subsequently AI if we are able to put in. The more we know, the more factors we can put in to train the model, and the various paradigm shift that we're talking about from the gut microbiome. While we are looking at this is really just one final slide, and actually going back to the UIA TAS paper, where when we look at aneurysm, sometimes we get very caught up into predicting a rupture risk. But we also have, before we want to decide on treatment, it is important then to know what is our own personal treatment risk, and balance that before we offer treatment to our patients for unruptured aneurysm. With that, that will conclude my presentation on the unruptured aneurysm, and I thank you.
Thank you very much, Professor, for your excellent presentation. We all can see that the data available in order to make a proper decision in this kind of patient is extensive. I think we're going to discuss at the end all of this. But I want to say something about this Raja, because it's very important. This is one of the best presentations I've ever seen. Very up to date and everything. Congratulations, and I hope at the end that all the people here in the forum and the people who are watching these lectures have any questions I'm sure that you can answer, Professor. Thank you.
Thank you very much for your compliment. Thank you.
We can take the few questions from the panelists. We can start with Joe. Yeah.
Hi, Robinson. Thanks very much. It's definitely a very comprehensive and up-to-date presentation, and I've learned a lot from it. I'm Sam from Penang, Malaysia. I would just like to ask, for your practice, which do you use and how do you decide to offer treatment, and whether clipping or endovascular, if you offer them? And
thank you. So if you're talking about the risk prediction, just now, as I said, we would usually use the 3 scores, and I shared the website. And also at certain point in time where we have, especially within that 4 to 5 measurements of the size itself, we do the wall enhancement with the gadolinium to look at whether there's enhancement and all that. I would stop that. I'm within my unit, we are looking at the CFD studies, but it is still at the research phase more than the clinical phase itself. And then if you're talking about the treatment modality itself, in my unit itself, we do have, if possible, a coiffure strategy, even for the unruptured aneurysms. I know that's not quite where the traditional ISAT studies it is, but I guess most of the time, looking at our patients, they do try or prefer sometimes for a slightly less invasive technique, if it's possible. But what we do is we have now 3 groups of doctors in our unit. So we have our interventional neuroradiologists, and also we have the surgeons who are able to do both clipping and coiling. We're also then training a group of hybrid neurosurgeons who is able to, because of this, without bias on the preference on the treatment, to come and discuss if we are going to treat an unruptured aneurysm. Thank you.
okay, thanks.
Thank you very much. Yes, Liu, would you like to ask something?
Thanks, Raja. Thanks, Prof, for a very comprehensive talk. I have 2 questions, Professor. First is, usually for unruptured aneurysm intraoperatively, we would like to find out the wall thickness to avoid a premature rupture intraoperatively. And also you presented on the different hemodynamic changes which cause the changes to the wall of the aneurysm. Do you think that at this point of time, do we have adequate technology to actually measure the wall thickness? And you think that in the future, the wall thickness will be incorporated in any of the algorithm, including AI? My second question, Professor, we are talking about probability of a rupture and also the risk of surgery, but we hardly hear actually in relation to the location of aneurysm and the age and the risk of surgery, especially for unruptured aneurysm. So how do we actually do this kind of relative probability, whether a patient should take risks waiting for the aneurysm to grow, or why don't we offer some treatment? Is the risk is very high? So we do not have this figure at all in any publication. Thank you, Professor.
Thank you. So actually, the wall thickness itself is a surrogate measure. As in the presentation, really, what you're hoping for really is going to be looking at the hemodynamic factors itself, and subsequently looking at all the not only the wall thickness, is the geometry of the aneurysms, which is easily nowadays much easier to look at. And what is difficult to measure, as you mentioned, is really the structural, and that's where to characterize the aneurysm more difficult in that sense. The hemodynamic factors is more or less fairly standard practice in a very advanced units to put it in. And you're right that then you're talking about the treatment risk. Unfortunately, that's actually and I talked that in the last slide of you can obviously present the treatment risk based on the established literature in the World Best Centers with publications of this is the risk of clipping, coiling, and all that. But it's important then to also know internally your unit based on the departmental audits, what is our own data and how you offer to the patients. I think that will already give the patient the best guidance in that sense. And that's why having to know your own departmental results. And the database is crucial in terms of making sure that the data and the technology will come subsequently. Thank you.
Thank you. Jayanan would like to say something. He also is one of the biggest centers which treats aneurysm. Please.
Yeah. Thank you, Raja. This is an excellent paper and excellent work. Comprehensive review of the whole process of decision making in unruptured aneurysms, and I must thank you for quoting my paper as well on the natural frequency of aneurysms. We are actually doing some work on fluid structure interaction studies as well, and as Professor Liu said correctly, that there is significant difficulty in imaging the blood vessel wall and aneurysmal wall thickness to get accurate FSI simulations. And I think that in future, maybe imaging will develop in such a way that we will be able to image the wall as such and evolve 3D models for FSI studies in aneurysms. Thank you.
Thank you very much. Prof. Minaharu, would you like to say something?
Thank you for your great talk. And I have two questions. As for the antiplatelet therapy, do you have any data that antiplatelet therapy reduces the enhancement of the vascular wall in the MRI examination? And my second question is, do you think the canakinumab, which is IL-1 beta antibody, because you think that the inflammation may be associated with aneurysm formation, then do you think the canakinumab, which decreases the expression of IL-1 beta, is effective in treating aneurysm?
Thank you, Professor Minaharu. From what I can gather, the effectiveness of the aspirin is still the linkage between taking aspirin, looking at aneurysm, decreasing the growth, and also associated with the decrease of the enhancement of the gadolinium. I am not aware of a particular paper. Maybe I stand to be corrected. That has actually been shown positively. In the study that I quoted, I think it's not based on MRI and decrease in an enhancement. And as to your second question on using anti-inflammatory, I think theoretically it is, but I'm not aware of the specifics actually. Thank you.
Thanks so much.
Thank you very much. If I would like to say something, that this is one of the best lectures that I have heard so far. on our webinars on UIAs. All the previous speakers were brilliant speakers as well. We have Prof. David Hassan also on our webinars, who was the first to suggest aspirin will decrease the risk of rupture in UIAs. But most of the advances you showed, the exact thing is the practicality of this on the application when actually a patient comes to you. As Prof. Mura said, you must tell the patient something, isn't it? You cannot just say that this stress is, WSS is high, you have to this, you have that. Would you treat this or not? So one thing, I know I have used the Hemoscope, the software, which was in when we were in Fujita. But it is very costly, 50,000 US dollars. So we cannot afford that sort of software in the low and middle income countries. So the practicality of what the score, and also the scores that you showed us, the scores are, I don't think it applies to people in the Central Asia, because most of the journal articles you read on the faces and which have applied to people in Central Asia for ruptures, the score they have given is 0 for population in Central Asia. So that is not 0 actually. This is center where we operate. We have around 100 aneurysms we operate. Okay, not there are others whom we defer surgery due to poor risk and all, very bad condition we do not operate. But around 100 people we operate, which are around grade 3 SAH and all. Of course, Jan and also operating on a similar number. So numbers are very high. You cannot say that it is you cannot quote 0 as the risk for rupture in Asian population. So, but the single most factor that I would suggest that it should be the size. I think size is definitely one of the most important risk factors that would suggest that yes, you should treat this patient. And also the association of comorbidities like hypertension. Other than this, history of SAH in the family is another important risk factor. So the practicality of a score coming up from Asia and LMI says, I think it's very different from what comes from other high income countries. What do you think, Prof. Vincent?
That's where I feel that medicine is an art and both in science. While here tonight, we are trying to chase the science of unruptured aneurysms. We are all going to look at whether the size, the shape, and the cutting edge of science and what it can tell us. I think it's also important also to look at the art of the patient in front of us, and actually the whole discussion of the risk threshold, whole feeling of what it means by treatment and all that is also important. So sometimes there's no perfect answer, and I'm sure all of us sit here and say, it's really a combination of the factors, and I don't think any of us will embark on their journey with our patients with full certainty, and we have to learn with that make the decision with as best information as we can get, so that if there's an adverse outcomes, we all know that we have done the due diligence. And I think that's all I can say specifically for every untreated aneurysms that are offered treatment.
Thank you. Thank you very much. We can conclude this session from the remarks by our Honorable Chair, Prof. Mura.
Yes, it was very nice discussion with all of our panel of experts, and I want to just say that you need to decide based in. I always seek in 3 factors. No, what we discussed today is something about the factors of the aneurysm, factors of the patient, and factors of the treatment team. You need to put yourself into the equation of the patient. It's very important. You need to be honest about this. Okay, it's very important in try to have a hybrid neurosurgeon in your service, or if you are not hybrid, you need to work with endovascular people. We always talk a lot about this so obsolete discussion of, between endovascular and microsurgery. And the thing you need to do is discuss the patients, treating a team base. It's the same for everything. For example, I do a few endoscopy in skull base. It's not my main field of interest. You know that I'm minimally invasive, but in order to be minimally invasive skull base, I need to do endoscopy. But I have an expert in endoscopy in my service. Then we work together. Yesterday we operated an hypophysis adenoma of the hypophysis. You know, the same is for the aneurysm. You need to put yourself in the question, okay? Because it's not the same. If you have, I don't know, 1,500 aneurysm treated in your experience, it's not the same if you have 50. You see, even if the aneurysm is the same, even if the patient is the same, you need to put yourself in the equation. It's very important for the young neurosurgeon. I know that I have experience because I have 28 years in this, but I start someday, 28 years ago. It's the same for the young guys. What the young guys need to do, you need to associate with the experienced neurosurgeon, and you can share experience. You can share the results for the patient. And then it's very important for us to collaborate with the young neurosurgeon. And the collaboration is in the operating room, is in the outpatient treatment room when you talk with the patient. I always I am with a fellow in my when I treat patients, and I when the patient come to me, I said we operate together and we offer you the best treatment. All of us offer you the best that we can do, and the fellow start the surgery, and when the fellow feels that is too much for him, I take over the surgery, and we offer a good result, you know. But this is a process, and then for me it's very important this activity because we share our experience. We have no magic number. Everybody talk about the magic number, the 7 millimeter is the magic number, you know. More than 7 we treat, less than 7 we don't treat. But I saw a lot of 5 millimeter, 3 millimeter rupture aneurysms, and sometimes I operate and I saw a tiny aneurysm of 2 millimeter with a bleb, you know, and it's almost rupture. And then I think, why we have these numbers? Because it's for the population. It's okay. We need to share this, but we need to collaborate. And we need to collaborate between the countries. We need to collaborate between the continents. We need to collaborate between the young and the old neurosurgeons. I consider an old neurosurgeon, and it's very important. We need to put ourselves into this big equation of the unruptured aneurysm.
Well, thank you very much. That was indeed a wonderful session, and we enjoyed a lot. We have just been updated by Prof. Shubin that the total number of people who have logged into WeChat, YouTube, and Zoom has crossed over 700. So it's been a wonderful session for everyone. So I thank both speaker and chair for this wonderful session. So I'll hand over to our second chair, Prof. Minaharu, to say a short introduction and invite Prof. Jayanand for his lecture. Prof. Minaharu, all yours.
Yeah, thank you, Dr. Raja. It's my very honor to be a chair session of the ACN webinar. As Professor Raja made an introduction, Professor Jayanand Sudar is an expert of cerebral vascular disease. The title of his speech is Does Arsenic Have a Role in the Pathogenesis of Moyamoya Disease? And Moyamoya disease is not a common disease, but the number of patients is increasing in East Asian countries, especially in China. This is probably because diagnosis accuracy has been improved. The major risk factor of Moyamoya disease is RNA213 gene mutation, and they are found in more than 80% of Japanese patients. And importantly, non-Moyamoya arteriopathy, such as middle cerebral artery occlusion, is also caused by the same mutation. RNA213 is also a risk factor for coronary artery disease and pulmonary artery hypertension. As compared with genetic factors, environmental factors are not well characterized. Daily drinking, low LDL cholesterol, and some microbiota are among the environmental factors, but other factors should also be involved in the pathogenesis of Moyamoya disease. And arsenic may be the one of the factors that is associated with Moyamoya disease. Today, Professor Jayanand will talk about arsenic as a risk factor of Moyamoya disease. I'm looking forward to his talk. Professor, please start your lecture.
Thank you, Professor Minaharu. Today I have embarked on a topic that is likely to be controversial, and I hope it will stimulate a lot of thought and debate. I'm just introducing arsenic as a pathogenic factor in Moyamoya angiopathy. I come from Sri Chitra Tirunal Institute for Medical Sciences and Technology at Trivandrum. This is located in southern India. You can see it's way down at the tip of the peninsula, Indian peninsula. Now, I must definitely thank Dr. Raja and Dr. Liu to have permitted me to present this topic, because this topic is very novel and unlikely to have much of scientific backup. But I find that there is some reason to present this before this audience because of the correlations that I have found. And we have recently published a work too. So I'm open for discussions. I may be proved wrong in future, but that is what science is meant for. Now, this is a paper by Professor Akio Koizumi in 2012, I think, 2016. He was talking about the influence of an environmental factor in Moyamoya disease in addition to RNF213 gene mutation. He perfectly told that another factor is needed to explain the low penetrance of having an RNF213 mutation in Moyamoya patients. But he was not the only one who has invoked an environmental agent in the pathogenesis of Moyamoya. There were many other researchers who were thinking about environmental factors, like Fee et al. Said various environmental factors have been proposed as etiological factors. Environmental contributions to Moyamoya pathogenesis is still awaiting investigation and elaboration. Now, these are the pertinent questions that I would like to ask. Is there an environmental factor involved in Moyamoya angiopathy pathogenesis? Could there be a link between arsenic and Moyamoya? Why is the disease more common in Japan, Eastern China, and Korea? Is there a dietary influence? Why is there an increasing number of Moyamoya cases over the last decade? And why is there an increase in the number of cases from non-endemic regions, that is outside the known regions, Japan, China, and Korea? So this came up in Progress in an article titled Progress in Moyamoya Disease. This shows the global prevalence of Moyamoya angiopathy cases, and you can see that the predominant areas where Moyamoya is prevalent include Japan, China, and a few cases in the United States, India, some in Eastern Europe as well. Now, this is from the same paper showing the global increase in prevalence over the years. This data is slightly primitive, but this paper came up in 2020, although the data is slightly old. You can see the prevalence in Korea has increased from 2007 to 2013. In Japan also, the data says from 1994 to 2006, you have an increase. Also in the US, you have an increase, but the percentage of familial cases has been high in Japan. Now, these are individual data from each of these countries. I have given the references as well. Now, if you see the Chinese map with the number of cases of Moyamoya described, you can see that the provinces that have the highest number of cases include the Henan, Hubei, and Shandong. I think there's one more province that I'm not able to pick up the name. But you can see the general area where these provinces are located, where the Moyamoya cases are high. And this is another paper that came up in 2021 in Lancet, and this also shows the predominance of cases in Eastern China. In the United States also, as I said, the prevalence has increased over time. And this is the South Korean data. You can see the progressive increase in the number of cases reported. Now, this is our data. We have analyzed our data from 1999 to 2023, and we have this progressive increase in the number of cases. Although the case numbers are not so high, we can see that there is a gradual increase in the number of cases coming up for treatment. Now, how this question of arsenic started is this. A 9-year-old boy who suffered from Moyamoya came to my OP after his treatment for Moyamoya. He underwent bilateral revascularization surgery, and his mother asked, "My son eats soap, and do you think he got Moyamoya angiopathy because he eats soap?" I said, "No, there's no evidence for that." But this ticked me off, and I started looking at what the soap had to do. And if I started looking at various aspects of soap, and these were some interesting things that I found. This is in 1896, there was something called Dr. Mackenzie's arsenical soap, which was used for treatment of pimples and spots and blemishes on the skin. And it guaranteed a lovely complexion as well. Now, this is further an advertisements of the same soap, but incidentally, there is no arsenic in these soaps. This is another significant paper that came up in 2005 in Current Science, which is published by Indian Institute of Science. This reports by Professor Sabyashi Sarkar. He was the former head of the Department of Chemistry of Indian Institute of Technology, Kanpur. He has given a small research communication in this journal in which he has found that arsenic levels are actually high in many popular brands of soaps and detergents, and that this soap could be damaging to our environment and possibly leaching arsenic into groundwater sources. Now, we also segregated our data based on geographical location, and we found three clusters: the eastern cluster, the western cluster, and the southern cluster. Now, we have cases from other parts of India as well, but these three clusters caught our attention. You can see that one of these clusters that is located in eastern India, around where that is in the top right of the picture. I'm not able to use the mouse, but so that is where West Bengal state of India, and which is adjacent to Bangladesh lies. And on the western side, you have Gujarat state, and on the southern side, you have the states of Kerala and Tamil Nadu. So this data is based on the referrals to our hospital, and this could possibly denote a referral bias because there are only few centers in India that offer revascularization surgery for Moyamoya, and possibly this data is skewed. But it still gives us a representation of where our patients are coming from. Of particular interest is this West Bengal state in northeast and the adjacent Bangladesh. So this area has been historically known to have high arsenic in groundwater, and arsenic contamination, arsenicosis, arsenic poisoning, exposure to arsenic has been rampant in both media as well as scientific journals. And cardiovascular diseases, stroke, everything has been blamed on arsenic. And these are maps that show the hotspots of arsenic. You can see both the eastern part of West Bengal state as well as the southern part of Bangladesh are involved in having high arsenic levels in groundwater. The reason cited for this region to have high arsenic levels is because of its peculiar geographical location. You can see those blue arrows on the right denote the flow of rivers into the Sundarbans Delta, which has the Hooghly and the Ganga Brahmaputra rivers. And these rivers flow down from the Himalayas and reach the Delta region. So this Delta region is rich in alluvial soil, and the alluvial plains, as we call it, is more of brackish water stagnation, and loose soil. So what happens is the ores that contain arsenic, which are deposited in the Himalayan belt, they get washed down these rivers and finally get deposited in the alluvial plains of this delta region. And the other thing is that this opens into the Bay of Bengal. I'll come to the reason for this later. Now, you can see this is this map on the right side is actually by one of my collaborators, Dr. E. Shaji, who is a renowned geologist in India. He was formerly with the Central Groundwater Board in New Delhi, and now he is the head of the university, the Department of Geology at University of Kerala. And this is his map. This came up in Geoscience Frontiers. This shows the arsenic map of India. Those red spots show arsenic contamination in groundwater. Now, there is no one-to-one correlation, but definitely there's a pattern. You can see the alluvial plains in the northeast and the West Bengal region and the south as well as the Gujarat. These regions have some hotspots of high arsenic in groundwater. Now, we started picking up this data and looking further closely into this, and we thought we will analyze this particular state of Tamil Nadu in the south. Now, this particular state is on the southeastern side of the lower part of the peninsula of India, and you can see that majority of the cases indicated by the red dots in the right side figure are the geographical location from which these patients came. And we started looking into data from the Central Groundwater Board, and we saw that these patients actually come from regions that have been reported to have high levels of arsenic in groundwater, and these are labeled as green. We also looked at whether there could be environmental influences. A few of the patients said they come from places that have cement factories and copper smelting units. So possibly there could be an influence of environmental pollutants. Now, why is arsenic so important, and what are we looking at in this contamination and exposure to arsenic? If arsenic is ubiquitous in nature, everyone is getting subjected to arsenic. So what are the safe limits of arsenic? I looked at the WHO data in 2019, and I found that the dietary intake of the arsenic should not exceed 3 microgram per kg per body weight per day. And the drinking water, the standards for the global standards has been set at 10 micrograms per liter. And there are no safe levels of arsenic in air so far established by WHO. Now, the same report also carries this, that Argentina, Chile, China, India, particularly West Bengal, Mexico, US, and Bangladesh are the hotspots of arsenic contamination in groundwater. Now, the sources of arsenic in the environment can be multiple. They can be both natural causes as well as man-made causes. The natural causes are geological sources. Groundwater, as you know, has arsenic, and the surface water in alluvial plains. Industrial sources, coal mining and coal refineries are potent polluters of the environment with arsenic. Copper smelting units, as I said. Agriculture, there are arsenic-based pesticides. Arsenic is used in timber preservatives, especially to protect them from termites. They're also used in fruit orchard sprays. And food sources, the arsenic is found in to be enriched in certain food like fish, shellfish, seaweed, and rice that is grown in these alluvial plains. Now, why is arsenic of concern now? Possibly global warming and melting of glaciers in the Himalayas is driving the increasing arsenic in groundwater sources in the hotspots, that is in Bangladesh and eastern West Bengal. So what happens when glaciers melt? It exposes more of the iron, the arsenic containing ores in the rocks, and these get degraded into the water, and these continue to flow downstream and reach these alluvial plains. Also, this is compounded by the rise in sea levels. The rise in sea levels, what happens when the sea levels rise is that the sump where the arsenic has to be deposited into the sea is going more inland to regions where humans have inhabited over centuries. So in the Sundarbans Delta, you can see over the years from 1975 to 2020, the graph is showing that water has reclaimed most of the forest region. The blue represents the water and green represents the forest cover. So these were based on remote sensing maps. This data has been based on remote sensing maps. And you can see that the global warming and the rise in sea levels possibly drives a higher groundwater resources of arsenic. Now, the concept of virtual water, this has been discussed with Professor Shaji in the University of Kerala. What he says is the concept of virtual water is that if you have paddy or any kind of cultivation, vegetable cultivation in arsenic-rich soil, this gets bioconcentrated in the rice and in the produce, in the vegetables and the fruits, and this comes to the table in far off places. This food is exported. The grains are exported. It can be transported over land to other places which are not endemic or not known places to have high arsenic in the groundwater, and this exposes populations beyond those hotspots to high arsenic levels. Now, the other concern is overexploitation of groundwater resources. You all know that the urbanization has gone to such an extent that the people have to rely on groundwater sources and any sources of water for their daily living, and this tends to deplete the groundwater sources. Now, what happens when you take more and more of groundwater for daily use? The problem is that the groundwater tends to keep the arsenic levels at a certain concentration. But when you deplete the groundwater stocks, the relative concentration of arsenic in these groundwater sources continues to increase. And this is what the population is being exposed to. Now, the other is industrialization and pollution, which again is inevitable in the developing world. you can see copper smelting units as well as I said, the coal firing thermal power plants are notorious for pollution of the environment with arsenic, both into water resources as well as into the air. And agricultural practices like pesticides, which contain arsenic, which I know many countries have banned arsenic-based pesticides, but they are being used illegally even now. And there are certain situations where even the packaged produce has been recalled from shelves because of high arsenic levels. For example, this Ven's baby cereal powder puree, which was recalled from shelves of Singapore because of high arsenic content. Now, seafood is also a particular good source for arsenic. And what happens is most of the seafood is bio-enriched with arsenic. And some of these foods actually enrich this arsenic much more than others. And particular concern is seaweed and shellfish. Now, a look at how arsenic exposure can occur in humans in the Indian context. In West Bengal and Bangladesh, adjoining Bangladesh, because these two are geographically adjacent, I want to take them together. Groundwater and drinking water resources, which are contaminated with high arsenic levels, is already proven. Fish cultured in brackish water, fish caught from the rivers, River Hooghly, from the River Brahmaputra, Ganga, all have been noted to have high levels of arsenic. And sea fish caught from the Bay of Bengal in the vicinity of the Sundarbans Delta also is bio-enriched in arsenic. And the rice cultivated in the sub-Himalayan alluvial plains is also targeted. Now, in Tamil Nadu, in southern state of Tamil Nadu, we looked at the situation, and groundwater and drinking water contamination is a reality there. Industrialization, as I said, copper smelting units and thermal power plants which fire coal, these are possibly of concern. And in Gujarat, in the western state where we have the western cluster, there is definitely a serious issue caused by overexploitation of groundwater. And the groundwater apparently has been consumed up to around 60% of its resources. And this has been caused alarm, and the government has raised red flags regarding this. And Gujarat is very highly industrialized as well. So the water requirement in such industrialized locations is very high. Now, is the situation actually confined to India? We looked at things outside India, and this paper caught our attention. This came up in November 2020, and it speaks about high prevalence of Moyamoya syndrome in Appalachia. So this refers to the Kentucky state in United States. And the top right figure has been adapted from the same publication, which shows the distribution of Moyamoya cases that they have seen. And this they have reported as an unusual rise in Moyamoya cases in this community, in the Appalachian community, that is those residing in the hills and the foothills of the Appalachian Mountains. And I started looking at reports from this region, and I found that there are a lot of defunct coal mines, and coal ash has been buried in these mountainous regions. And what happens with buried coal ash is that it tends to leach arsenic into resources, into the rivers, into the wells that are used for domestic purposes. And there are articles to substantiate this. The collaborative response to arsenic contaminated soil in the Appalachian Kentucky neighborhood. And they found alarming levels of arsenic in the soil. They also looked at the nail samples and the hair samples of the people living in these regions, and they found that this also had high residues of arsenic. And they also found that the resources, the well water tested, also had high levels of arsenic. The Chinese scenario is also no different. You can see that the regions of eastern China, the provinces that are having the highest number of Moyamoya cases reported. This is based on the references that are given below. These maps are derived from these references. And you can see that, interestingly, the highest prevalence of RNF213 mutation is also from these provinces. But of interest is this: the population at risk of arsenic exposure is also in this region. And you can see those green dots in the left figure, those represent Hijiki cultivation zone. That is the zone that cultivates the seaweed named Hijiki. I'll come to the reason for this later. And on the right side, you can see the yellow panels representing the areas that are highly populated, areas with high air pollution and air pollution with arsenic, as well as the location of copper smelting units. Now you see that the similarity between the geological regions of Bangladesh and West Bengal and the regions in China. They are in the alluvial plains, they are in the river delta basin, and probably the same mechanism that is occurring in West Bengal and Bangladesh is possibly acting in eastern China. What about Japan? Japan has been noted to be one of the places where Moyamoya is highly prevalent, and we found certain articles from there as well. And the Kyushu region of Japan having high arsenic in geothermal waters, and what they have seen is very clear here. Very high arsenic concentrations, more than the designated levels, were detected in most geothermal waters sampled, and this is in Kyushu Island, southernmost. How about Hokkaido, the northernmost island? This is as recent as July 2023, and high levels of arsenic were detected at a steam spew in Hokkaido. And I have taken this sentence out of this news item: 15.9 milligrams of arsenic per liter, which is 1,590 times higher than the standard for drinking water. So if you have very high levels of arsenic in geothermal springs, I'm sure that is going to percolate down into the alluvial plains, into the farmlands as well, and contaminate soil, and possibly rice that is consumed from these regions is also going to be high in arsenic. Now, dietary practices in Japan, particularly seaweed. Hijiki, I'm informed that hijiki is a common seaweed that is consumed in Japan. It is cultivated in eastern China as well as southern Japan. This seaweed is known to concentrate arsenic, and the large brown kelp, also known as wakame, as well as the kombu seaweed, also contain high levels of arsenic. Now, this is an article that came in 2019. Hijiki seaweed consumption elevates the level of inorganic arsenic intake in Japanese children and pregnant women. Now, I think Professor Mineharo told about beer consumption, and I can see a connection between beer consumption and arsenic. You can see that the rice that is grown in arsenic-rich soil is obviously going to have high arsenic sediments because of bioconcentration, and the same possibly is used for fermentation of sake and beer, and possibly this could result in high concentration of arsenic in beer as well. And this has also been reported. You can see the reference in the bottom of the page: association of beer consumption with arsenic concentration in urine result from general Japanese population. Also, raw fish and that is consumed in sushi and sashimi could also be responsible for high dietary intake of arsenic in the Japanese population, because raw fish has more arsenic than processed fish. Now, this is based on a previous slide that I had shown. The WHO had highlighted the hotspots are Argentina, Chile, China, India, etc. But why not Argentina and Chile? Possibly this is because of a human adaptation to arsenic-rich environments. Like the population in Andes and Chile is resistant to the ill effects of arsenic because they are genetically programmed. They have enzymes that metabolize the arsenic much better than the populations elsewhere. Now, if you see closely the map that I had shown initially, the middle one, the blue and the red one, that shows the cases of Moyamoya that had been referred to our hospital, and that is the Kerala state. And on the left diagram, you can see that Kerala is not actually a state that has been flagged for high levels of arsenic in groundwater, apart from other states that are marked in brown. But if we look at our data over the years from 1999 to 2023, you can see that the incidence of Moyamoya has steadily been increasing in Kerala as well. And recently, there is just 1 week back, the Central Groundwater Board released this statement that Kerala, particularly the district of Kollam, has been noted as a hotspot for arsenic in groundwater. So the National Green Tribunal in India has issued notice to this state about this alarming increase in arsenic in the groundwater. And we looked back at our data on the patients from our state, Kerala, and found that majority of the patients come from the same district, Kollam. Now, what is the role of arsenic in relation to the RNF213 gene, which has always been standing in front of Moyamoya pathogenesis? Now, based on literature review, we proposed 4 possible ways how arsenic can actually influence RNF213 gene. So if you have patients who already have the gene mutation, if you can see the topmost panel in the right side diagram, RNF213 mutation is already existent. So if you go by Professor Akio Koizumi's work, that not all patients with RNF213 mutation actually develop Moyamoya. Does it mean that only those that have a second hit caused by some other factor actually develop Moyamoya? In this paper, I propose that arsenic could be this factor that causes the second hit in this pathogenesis. Arsenic is also known to act through the protein expression of RNF213 gene, that is mysterin. Arsenic binds with the ATPase and the E3 ligase sites and results in altered proteostasis. That is, the protein expression is altered. So the result of this is that it looks like the RNF213 has been mutated because of the proteomic expression, but in reality, the RNF213 is not mutated. Arsenic possibly plays downstream to cause this alteration in proteostasis. Arsenic also acts on CPG repeats before the RNF213 gene by hypermethylation, and this possibly acts in a different mechanism. RNF213 will not be able to express normally because of this hypermethylation of CPG repeats before its location, and this also possibly results in the pathogenetic mechanism. And arsenic is also known to cause direct chromosomal and genetic mutation. So these 4 possible pathways have been proposed. Now, this is a previous paper of ours wherein we have invoked multi-hit hypothesis, the mechanobiological theory of Moyamoya angiopathy, in which we have highlighted that arterial tortuosity, vascular angles, wall shear stress, blood vessel wall strength, blood rheology or viscosity, and molecular factors all together contribute to the genesis of Moyamoya angiopathy, and possibly the environmental factor is likely to act at the molecular level. And this is the figure from that same paper in which we have identified almost all the syndromes that have been so far described in Moyamoya angiopathy and linked the molecular pathways that could be responsible for the development of Moyamoya angiopathy. And if you see, the pathways involved are the MAPK ERK pathway, the JAG1 pathway, the SMAD pathway, the PI3K AKT pathway, the JNK pathway. All these result ultimately in an increase in matrix metalloproteinases with a corresponding decrease in tissue inhibitors of matrix metalloproteinases, which is represented in the top right part of the slide. This results in ECM degradation, and the other pathways that are involved result in smooth muscle migration and proliferation. The two contribute to intimal thickening and endothelial proliferation, ultimately leading to Moyamoya angiopathy. So you can see how all these factors on the left panel play together, and all the syndromes that have been so far described having Moyamoya angiopathy can be linked by these molecular pathways. Now, is arsenic the catalyst in all these pathways? I think so, because all the pathways that have been described in the 2021 paper have been influenced by arsenic. I'm not able to put the references for all of these here, but you can go through my paper, and all these pathways have references that arsenic does influence all these pathways, and the result is an increase in matrix metalloproteinase and decrease in TAMP, resulting in Moyamoya angiopathy. Again, the question, arsenic is ubiquitous in nature. Everybody is exposed to arsenic. Why only some people develop Moyamoya angiopathy and not all others? So this is where I put in that not all individuals with chronic exposure also develop Moyamoya angiopathy. Not all individuals with RNF213 develop Moyamoya. The susceptibility to arsenic and arsenic metabolism is also again regulated by the genetic background of the individual. And susceptibility to Moyamoya could possibly occur in those individuals who are susceptible to the toxic effects of arsenic with a genetic predisposition to Moyamoya angiopathy. This is our paper. I invite everyone to go through this paper in detail, and I'm open for discussions as well. To conclude, arsenic could be the environmental catalyst for Moyamoya. The global rise in Moyamoya angiopathy could be linked to increasing exposure of arsenic, and this is probably driven by climate change, the melting of glaciers, the rising of sea levels, dietary influences, industrialization, urbanization, and exploitation of groundwater resources. Definitely, further studies will be required to prove this hypothesis, but arsenic exposure mitigation strategies have to be considered at the community level where Moyamoya is prevalent. Thank you very much.
I was so impressed by your great talk, and the association between Moyamoya and arsenic was analyzed in the geographical analysis, and it is very convincing that arsenic may be involved in the pathogenesis of Moyamoya. Before I make questions, I'd like to the audience to if you have some question, please ask him.
Joe, would you like to ask something, Joe?
Yeah, I actually went through just now quickly to see if Malaysia has some arsenic poisoning and all that, and it seems like our current prime minister actually had a history of arsenic poisoning as well. So there are a few geographical areas where there are. So next time if I come across again my Moyamoya patients, maybe I would ask them if they are taking a lot of Japanese food and the areas that they are living in. Yeah, there have been reports. Excellent talk. I think, like I said, it sounds convincing. And if we do find a link between this and Moyamoya, then maybe we can save a lot of people from getting it in the first place. Thanks.
Thank you.
Thank you, Joe. Prof. Vincent?
Definitely a most interesting talk. I definitely believe in your theory. I just want to find out whether there is animal models that you can, for example, showing the increase of this arsenic intake, and then the model of Moyamoya and all that, is that you have showed eloquently the possible form mechanisms. I was just looking towards whether you have literature on animal models, for example. Thank you.
Yeah, I think more than animal models, I think we'll have to go down to cellular and genetic research with arsenic.
Yes.
Because animal models of Moyamoya are difficult to come by, and it is difficult to replicate the actual situation in Moyamoya. I think there are a few reports of animal models wherein they have introduced microcoils into the carotid artery of rats or rabbits and try to mimic the ischemia. But in the true sense, just by blocking the flow does not make it a Moyamoya model, because I think there are many more factors. If you go through the paper on the mechanobiological theory of Moyamoya, we feel that the strength of the blood vessel also has a lot to do with the occurrence of Moyamoya, particularly in syndromes like Marfan syndrome, where some patients develop Moyamoya. You can have a floppy blood vessel wall, and the changes in the wall shear stress in the supraclinoid ICA possibly result in the endothelial proliferation in that region. And this has been proposed in that theory. And that is why I feel that generating a animal model for Moyamoya is actually very challenging.
Thank you.
Thank you very much. Prof. Mura?
Yes, it was of course a very interesting presentation, and I agree that in Chile we have the Moyamoya disease is not so frequent. I have I have a concentration of the cases because they sent to me for the revascularization, but for me it's not so often. Maybe one Moyamoya for months or each 2 months, you know. And for us, it's much more frequent in child. Okay, but I see Moyamoya syndrome in adult patients as well. But as you tell in your lecture, it's difficult to differentiate in my country the region, you know, because we are completely isolated in Chile. You know, we have the ocean in one side and and the Andes mountain in the other side. I talk a lot about my colleagues about the geographical isolation of Chile, because we behave like an island. For example, I talk with my colleagues that we need to leave the stitches in the skin for 3 weeks. We take before 3 weeks all the wounds open. And I talk with the Argentinians, for example, they just leave 2 weeks, and in Brazil just need 1 week to 10 days, and they can take it out without any trouble. But in Chile, we don't have that kind of behavior of the patient. I think we have this geographical isolation is very important in the behavior of the patient. And what you showed today, Professor, is not a surprise to me, because I always think about why we have this behavior in the Moyamoya. You see, say maybe we have some geographical reasons that we don't know, but it's very important to understand that the change in the climate change is going to show us a different behavior of the diseases. You see, and for example, in Chile, we have a lot of subarachnoid hemorrhage in August and September, all the years. But this is changing now. We are not seeing the same behavior of the subarachnoid hemorrhage now in the recent years, and that's because the change that we are having in climate change, and the water, mainly the water, the source of water is changing in every country, and we are taking more and more this deep seated found in water, and this is going to take us more exposure to the arsenic and other minerals, because we are taking from very deep in the ground now, because the lakes are dry, and everything happening that way, and we need to be prepared. And I'm very happy for your presentation, because it's the rationale of this is very interesting, and thank you for this nice presentation.
Thank you.
Thank you. Indeed, it was a wonderful presentation, and we are nearly convinced. But of course, we'll need to wait for other evidences as well. Prof. Minaharu, what do you have to say?
Yeah. Indeed, Japanese people consume a lot of seaweeds, and it is also reported that the rice contains larger amount of arsenic than other countries. So the arsenic hypothesis may explain the high incidence of the Moyamoya disease in Japan. And I also checked the distribution of high arsenic region in Japan, and it is somehow it's matched with the high prevalence region of the Moyamoya disease. So it's quite interesting. Now I developed the in vitro vascular organoid model of Moyamoya disease using the iPSL model. And it is very difficult to develop the animal model, but we can develop in vitro model. So maybe we can collaborate with each other to check the association of arsenic in the development of Moyamoya disease. And hypermethylation caused by arsenic is a very interesting hypothesis. And I have one question to the professor, that what do you think is the most important molecular pathway that is the arsenic can lead to Moyamoya disease? You have a bunch of pathways, but what are the most interesting pathway, do you think?
However be the pathway, the ultimate result is that there will be an increase in matrix metalloproteinase and a decrease in tissue inhibitors of matrix metalloproteinase. So how it occurs, it doesn't really matter, because the multitude of syndromes where Moyamoya has been described need not involve RNF213, need not involve arsenic even. Has to just go and elevate the matrix metalloproteinase and decrease TAMP. That is what the complex algorithm showed, that the ultimate goal of all these molecular pathways is that imbalance. And that imbalance is possibly the key component, key pathway to the pathogenesis. Regarding arsenic's role in the mutation, I am still not sure. Between those 4 hypotheses, I'm not sure which of those is actually going to be true. But if you check the proteomic expression of RNF mutation negative Moyamoya individuals and compare it with the proteomic expression of the RNF213 mutated individuals, that might give you the clue whether this actually acts through the downstream pathway affecting the protein mysterin or not.
Do you have some plan to measure the arsenic level in the blood in patients with Moyamoya? And maybe you can compare with the patient with Moyamoya and the other cerebrovascular diseases.
Yeah, the thing is that the postulate is that it is chronic exposure. It is not acute exposure. It is chronic exposure of arsenic that is possibly causing this. So rather than blood samples, we may have to look into hair and nail samples and analyze the arsenic content. So we do have plans to start a study in our own state, Kerala, where we are seeing a slightly increased incidence of this disease over the last 2 or 3 years. And we are possibly trying to find out what the dietary influences are, as well as go into the community and see what is the water they're consuming, whether there's any industrial effluent that is affecting this place, and particularly look at whether they have an exposure to arsenic. And the controls in this case will be definitely the family members who are not affected by Moyamoya.
Do you have some familiar cases of Moyamoya disease?
Very rarely. We have a father-daughter, and one of my colleagues in Chennai has reported twins having Moyamoya.
Maybe it's very interesting to measure the arsenic level, the difference between the patient and the carriers. And I have one more question. Have you also searched for the relationship between the arsenic and the other vascular disease or other, how can I say, the inflammatory disease or something like that?
I have not explored that, but definitely there are reports of arsenic and its relationship to cardiovascular diseases. There are a lot of papers from Bangladesh as well. So possibly arsenic does have a role in altering the molecular pathways in the endothelium and subendothelial region.
Thank you. Thank you so much. So many ideas and collaborative ideas have come up in this. We hope to see this combine and get into a fruitful, meaningful research later, and we'll have a new hypothesis which has been validated. So thank you very much, Prof. Jayanand and Prof. Minaharu, for this wonderful session. So now we come to the concluding part of this session, and I'll close this officially on behalf of the Education Committee of the ACNS and the President, Prof. Yuko Kato. I would like to thank good speakers of today, Prof. Vincent Eng and Prof. Jayanand Sudhir, as well as the chairs, Prof. Jorge Mura and Prof. Yohei Minaharu, for the time and support for the ACNS webinars. Very special thanks to my co-host Dr. Liu Bun Seng and as well as my co-host Jo Isam for joining me today. And a special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.